All right. This is well, I guess one of the review videos for your upcoming trauma exam. I'll have a more blanket review video out in a little bit, but I wanted to start by focusing on this one section that we didn't spend a ton of time on in class, and that is specific injuries. I think is what your textbook calls it. Like what they call that section is specific injuries in the ortho chapter, because these can be really high yield for test questions, and for our assessments. That there are certain little indicators that really point out this kind of ortho injury is what we're running into. So these are the JBL slides. I wasn't going to make a whole new set of slides just to make this quick video, and I wanted to get it out today at least. Hopefully your long format video will be out later tonight. But these are what we're starting with, so that you guys have something that we haven't talked about in class yet, and then I'll have my normal long form based directly off your exam video out soon. And your study guide is already posted on Moodle for the upcoming exam. I know a lot of you guys are very nervous. I'm not going to say don't be nervous, because hopefully the nerves are making you prepare well for your exam and study and all of those things. But don't pull your hair out just over this one exam. You've all made it this far, so you've passed your first four exams. And this one is going to be pretty similar to the way that those ones were. We'll keep going in the course. All right. Starting in the middle of the slides here, so there's no welcome slide, just jumping right into injuries of the clavicle and of the scapula. I hope that you guys can see me somehow in the recording. If not, I'm sitting at Doug's desk, and you all know what that looks like because I've released videos from here before. So starting off with the clavicle and the scapula. The clavicle is our bone. Actually, I really do hope you guys can see me, because I'm going to do a lot of gesticulating in this. Um, the clavicle is our bone that runs from the sternum over to the shoulder joint. It's very exposed. Honestly, in most people, regardless of the amount of, redundant tissue or adipose tissue that we have, the clavicle is pretty exposed to injury. So it becomes, one of those bones that gets broken really easily. There's not much to pad it, no matter what your body habitus is. So a lot of times when we break the clavicle, it can initially present, maybe as a shoulder injury, because a lot of our mechanisms tend to point towards shoulder injury. They fell onto their shoulder or something, when really what we have is a compression injury from where the clavicle hits the shoulder joint and gets squished and it snaps. And we start to feel that pain when we move our arm around, because every time we move our arm around a little bit, our clavicle has to move. It helps to sort of stabilize the shoulder joint using the sternum and the sternoclavicular joint as like a fulcrum to pivot across. So originally, we walk up, we see our patient, maybe they're holding their arm like this, because by stabilizing the shoulder, we're also stabilizing the clavicle. The easiest way to find where this actually is, we should be inspecting and palpating all these injuries, just like we always inspect and palpate our trauma patients. And when we go to inspect and palpate on this patient, they're going to report less pain, up in our humerus and in our actual joint here in the shoulder. But as we palpate across to the clavicle and across the back to the scapula, they're going to have a lot of really severe pain right on the clavicle when we palpate on it. Maybe we'll get a little bit of that crepitus, whatever, but I would bet that by the time you get, right into enough pressure to even call it palpation over the clavicle, they're going to be signaling to you that there's enough pain that you don't even need to feel the crepitus. You can be confident that there's something damaged here in this area. You might be able to visualize a deformity to it as well. Maybe, maybe not. But luckily, treating these are relatively simple. We're going to sling and swath it similar to if it was a shoulder injury, because a lot of the comfort in stabilizing is going to come from stabilizing the shoulder. We want to stabilize, like we've always said, one joint above and below. And if we consider the clavicle, then the clavicle has one joint above and below. It's not the ones that we think about as often, but the clavicle comes over here. It has a joint with the shoulder, and then it comes over here and it has a joint with the sternum. Well, our sternum's pretty well fixed in place. It's probably not going to move a whole lot, hopefully. So our shoulder is what can move around and cause this pain to develop on the clavicle. So if we stabilize the shoulder by putting it in that sling and swath, we also stabilize that clavicle from having a lot of gross movement, and that can help a lot with pain. So clavicle solved. Um, Injuries of the scapula. This is a big bone. I wish there was a picture on here, but big triangular-ish shaped bone in our back and covered in big muscles of our back. So not a super common uh, fracture that we see. Another one that's difficult to differentiate in the field between, is this a fracture of the scapula? Because it's probably not going to have a lot of deformity with all those muscles holding it in place. Um, so difficult to differentiate. Is this a fracture of the scapula? Is this just, really bad, high mechanism of injury to the back that's caused this bruising that brings all this pain? And right along with that, the dangers here are really about the possibility that if we have a scapular injury or a scapular fracture, we also might have rib fractures underneath it. And those rib fractures could cause a pneumothorax or a pulmonary contusion. These are worth talking about because we um, you know, need to discuss the ABC issues that come along with them. But once again, our scapula, unless you're one of those cool people that can actuate their scapula independently, our scapula is mostly interacting with the shoulder joint. So if we stabilize the shoulder joint, we can manage some of that pain, um, and bring them to the hospital. Look out for respiratory distress and those signs of ABC underlying issues. But in terms of the scapula itself, sling the shoulder. This is pretty much what I had just said. We splint these with a sling and swath. Shoulder dislocation. We talked about these a little bit today in class. Usually we have anterior dislocations. They can be pretty painful. And our normal treatment for a shoulder injury, we usually think is sling and swath. But when our shoulder joint is dislocated like this, excuse me, when we're dislocated like this, trying to get the arm into this position can be pretty painful. What we often end up doing with these patients is splinting them just in whatever is the most comfortable position. That might be letting their arm just hang low, on their side, and we try and stabilize it in that area. Or what one of our fantastic lab instructors had mentioned, Alana, was what these patients will eventually often end up getting is a sling that has a big foam block that helps separate the arm from the chest, and that can be a little bit more comfortable of a position. So if you can, if they can comfortably hold their arm at this like slung angle, but out in front of them, we can put that sling on, and then we can support that sling away from the chest with a couple of pillows, or in our case, a couple of blankets, because pillows are the most rare commodity in a hospital. And that might be able to stabilize more effectively than trying to just strap it down to their side, and still provide that comfort. Remember, we don't want to try and splint these things in a way that we're forcing them into a position of pain. All right, fractures of the humerus. Any of our long bone fractures can occur proximally, mid-shaft, or distally. Here they say consider applying traction to realign the fracture before we splint it. Remember that at least here in New York, we're not going to apply traction to any of these long bone injuries unless we don't have that present circulation, motor, and sensory distal to where the injury is. So 99% of these injuries, we're just going to do the sling and swath like we talked about. If we don't have the intact CMS, then we might apply some traction to try and realign things. Elbow injuries. This is the ideal case for what we talked about in class today, where being able to say it's a fracture or it's a dislocation is really difficult, especially in the context of whether or not it's both of them. Often, if it's one, it is both of them. Uh, the elbow, sort of like we talked about with the femur and the hip, the elbow itself doesn't break because the elbow itself is not a bone. So an elbow fracture is usually a distal humeral fracture, just like a hip fracture is actually a very proximal femur fracture. Um, these can happen to anyone, usually in the context of a fall or exercising, something like that. It says here they commonly occur in children. When I was a child, I had a distal humeral fracture with elbow dislocation. Um, and that was the only thing I've ever dislocated, I think. These are really painful, at least until they are reduced. Once they are reduced, like a lot of dislocations, they can, have a resolution of pain really quickly. In our older patients, sometimes it might come with PT. In our younger patients, a lot of times they get popped back in and sent on their way, maybe to wear a sling for a little bit. But we want them to, use that elbow a little bit, and a sling pretty well immobilizes the elbow even more than it immobilizes anything else. Dislocation of the elbow. This is not something that we reduce in the field. I told my story in class today about my patient I had that had a dislocation that was just like this, where it looked like his arm was like this, even though the elbow was pointing in this direction, and he had actually just dislocated it completely up and back around in the other direction. This is sort of a proximal ulnar fracture that would still be part of the elbow injuries group, where we cannot extend out our elbow. We get stuck in this flexed position because when we extend out our elbow, this particular bone marking of the ulna rubs along with another bone, and if it's fractured, it's very painful. Fractures of the radial head. This is another one that is going to be relatively hard to differentiate definitively. This is not a test question indicator that I would say I've seen a lot of times, the inability to rotate the elbow or the wrist. But for your clinical practice, worth keeping in mind that this movement causes pain because remember that our ulna and our radius both participate in the elbow joint, but when we rotate our wrist, they need to be able to swap places. So my radius is right here, my ulna is right here, and then when I rotate, my radius needs to be able to move over here, my ulna needs to be able to move over here, which means some little bit of motion needs to be able to happen down here at the elbow end of those long bones as well. So assess our CMS, and we know how to splint these patients. A lot of times it's going to be with a sling and swath. If we can get them comfortably into that position, might also be worth putting that SAM splint that we talked about that runs all the way down the forearm and up the humerus on, just to give extra stabilization to that sling and swath. And then we go to the hospital. Forearm fractures, really common. Falls, running into things, anything like that, especially where we put our arm out to try and brace ourselves, we can get a fracture of these, and we splint them. Pretty simple. Most common splint method probably is that SAM splint that just goes down the forearm, something in the hand to maintain the position of function, and then a sling and swath to stabilize the elbow and the shoulder to provide some comfort. That's about it. Injuries in the wrist and the hand. These can be really hard to differentiate, especially wrist fractures, trying to differentiate between a sprained wrist and a fracture of one of these little tiny, many little bones that make up the wrist. So we treat all these patients like it could be a fracture, may end up just being a sprain. But fractures within the hand themselves, we splint all of these pretty similarly to how we splint, anything in the wrist, we splint pretty similarly to how we splint the forearm. We do that SAM splint down the arm, something in the hand to maintain the position of function, and then a sling and swath if it's appropriate. Fingers, your agency might carry commercial finger splints. If the finger is notably dislocated or deformed where those commercial finger splints don't fit onto it well. One method that we can do for these is you can buy these mini SAM splint finger splints. They're like, 2 inches wide by 4 inches long, or you can take a regular SAM splint and your trauma shears and you can cut it. The aluminum side's pretty thin, and you can make yourself a little finger splint out of that and wrap that around the finger in sort of a U shape, put a couple little tiny pieces of gauze or something around it. And go to the hospital. Pelvic fractures. I gave a long, long speech about my opinions on pelvic binders in the class and making sure that we are judicious in their use. I will try not to give that whole thing again. Um, Remember that there are big arteries that go through the pelvis. Pelvic fractures have the possibility to have an associated damage to those arteries, and the pelvis has a really, really large volume. So our pelvic fractures have the possibility to collect a lot of blood in the pelvis before we start seeing those outward signs like bruising, things like that. Um, just because I didn't know it when it was asked in class the other day, I'll look up quickly. The inner pelvis, it can hold about a liter. Um, and remember that the issue with a pelvic fracture is that when we get that open book fracture, that volume opens up. So that volume becomes more than a liter. And the goal of our pelvic binder is to, and only to, reduce the interior volume of that pelvis so that we don't have too much bleeding inside. Um, we can lacerate a lot of these internal structures as well, the rectum, the vagina, and the bladder. The easiest way to determine if those have been damaged is when we do our good trauma assessment. All of these things have external orifices. So if we're concerned about a laceration of the bladder, then we can look for hematuria when we do our exam. If we're concerned about a laceration of the interior portion of the vagina, we can look for vaginal bleeding. And if we're concerned about a laceration of the rectum, then we can look for external frank blood draining out of the anus. So keep all those things in mind. When we have a pelvic fracture, we should be getting all of those clothes off and looking to see if those signs are there that could indicate worsened internal injuries. I will say the rectum, the vagina, and the bladder are hollow organs. They're all on the higher end of vascularized when it comes to our hollow organs, but they're still hollow organs. They're not going to bleed as much as a liver or a spleen laceration. Um, Anytime we have a patient who has had a high mechanism of injury, we should suspect a pelvic fracture. We should consider a pelvic fracture. All I'm asking you is that we apply pelvic binders to our patients, that we have palpable crepitus or open book pelvic fractures, and that we don't just apply pelvic binders to every patient with high mechanisms because we know that they can cause damage in certain cases. And note the possibility of hematuria, like I said before. When we assess our pelvis, we crunch, push, crunch, and we try and see if we can get the pelvis to move in a palpably abnormal way. We're feeling for crepitus while we do that, but we're also just feeling, like the pelvis is a very stable bone. It shouldn't be moving at all. So we feel for any movement that normally wouldn't be there, and we call that false motion. Dislocation of the hip. Hip dislocations require a lot of force, both to take out and to put back in. Those of you that go on to have some kind of position in the ER or to do student time in the ER at some point might get the chance to see a hip dislocation reduction. They are relatively violent because it takes a lot to push them back into place. These patients usually come from some kind of mechanism where the femur has had posterior force applied to it and it pushes itself out of the socket. And then we get it back in by pushing it back into the socket. Main thing with these patients is just a good assessment. Once again, difficult to differentiate definitively in the field. We have a couple more slides on this one. A lot of pain because this is so close to the sciatic nerve. Sciatic nerve is a big nerve, sends a lot of signals and can send a lot of pain signals up to your brain when it's being rubbed on by this femoral head that is squishing on it. Obviously, these people are going to come with a inability, most likely, maybe a severe pain on trying to move the joint, and that because of that, actuate their leg entirely. Harder to palpate than like a shoulder dislocation. Shoulder dislocation is pretty close to the surface. There's not a lot of other stuff around that area, so a lot of times we can see a notable divot on the shoulder. for hip dislocation, we've got our butt in the way, we've got our thighs in the way, which have big muscles and often big adipose tissue deposits in that area. So not something that we can necessarily just palpate around and say, oh, I can feel that that femur is not in its normal place. We're not going to put this back in the field, but of course we don't put really anything back in the field unless it's very necessary. We splint this, not with a traction splint. Be sure to keep our signs of a femoral fracture and differentiations from a hip dislocation really present in the front of our mind so we don't apply traction to this. We're going to splint this with one of our full-length leg splints or something like that. I would not say transport these people on a backboard. Probably a little extreme to put this patient on a hard backboard for a long transport. You can keep them supine, and that might help a little bit with comfort, but stabilize the limb with your splint and then pad around it to help reduce some of that movement in the back of the ambulance. Proximal femur fractures, what we normally call a hip fracture. Hip is the combination of two bones. It's not a bone within itself, so there's not really such a thing as a hip fracture, but a proximal femur fracture happens a lot from falls. Often they will crack off the neck of where the femoral head is. We have our femur, we have our femoral neck and our femoral head. A lot of times we can crack the femoral head off, or we can incompletely crack the femoral head off. We'll go put a nail in there to repair that. Really high yield in terms of test questions and your real life is that these patients will have a shortened, externally rotated leg. So the leg shortens because we've had that crack and those muscles pull the femur up, similarly to how when we have a midline femur fracture that we traction splint, they get pulled up. And then we'll have that external rotation because the head has been separated from the shaft of the femur, and that allows them to rotate out of the normal position. So our foot will be pointed outward. Make sure you assess for associated pelvis injuries. Usually our patients that have often these pathologic fractures of the femoral neck will not also have a femur fracture. The femur is a little bit sturdier than that thin neck of the pelvis is a little bit sturdier than that thin neck of the femur. But, we do our trauma assessment, we go head to toe, we look at everything just to make sure. Splint these the same way we would probably splint those hip dislocations. We use a long splint down the whole leg, and then we pad around it to try and keep the hips and everything in place. You can also secure these in order to prevent movement of the hip joint. You can secure the right leg to the left leg or the left leg to the right leg so that neither of them can really move around on the hip too much because they're secured to each other. Femoral shaft fractures we talked about a lot today when we did traction splinting, so I'm not going to talk too much about these. We mentioned how these big muscles spasm and they pull on the limb, so we have this significant shortening of the leg, and that's when we pull traction, we pull that shortening out, and it can help with comfort. More big blood vessels, you have a femoral artery that runs through there, you have a femoral vein that runs through there. If those get lacerated, the femur, just like the pelvis did, has a lot of space in it that you can bleed into. And in this case, not only can that cause a lot of blood loss, it can also preempt you to something like compartment syndrome as that space fills up and you can get that self-tourniqueting of the lower leg. We talked about this. Obviously, we're going to check CMS on these people, and then we stabilize with traction splint, whatever flavor of traction splint you prefer. But for most of you, these will be the traction splint that is offered by your agency. Most agencies pick a traction splint, go with that traction splint. They don't carry a handful of different ones. But just to review so that you know what to look out for at your agency, probably the most common traction splint we have at our transporting agencies is still the hair. The hair is our classic traction splint. It's got two poles, one going down either side of the leg, and a crank on it that helps to pull traction. The Sager, or what we call in class sometimes the crotch splint, sort of looks like a crutch, and the upper foamy part of the crutch goes into your groin, secures to the leg, and then you can pull traction on that. The Slishman is one of our sort of backcountry wilderness small packaging. The whole thing's only about this big. You can self-apply it, and then you pull a string, and that pulls traction across the item. The KTD, or the Kendrick's traction device, is another small form factor, but you can't really apply it to yourself because the person who pulls traction needs to do so from the foot end. But find out what your agency has, practice with that one, either in class if we have it to offer to you, or when you're at your home agency, so that you're prepared for when you take a call with your agency. That's, the time you want to know how to use the traction splint. You don't want to practice every day with the hair in class and then your home agency of the Sager and you're stuck when it comes time to actually use a traction splint. I'm going to skip over when we use them. We talked about that today. Injuries to the ligaments of the knee. So ligament injuries themselves are ones that we have probably all heard of before, and it's all of our CLs, our MCL, ACL, all of those. Patella dislocations, which we've talked about before, and then fractures of the bones around the knee. So either the patella itself, the kneecap, or the tibia, or the distal femur, any of those things. Our ligamental injuries, you can look up, and it's not a bad thing to know the different tests you can do on the leg for damage to the MCL, damage to the ACL, and how you can push and pull or orient and twist on the lower leg to determine some of the indicators for damage to those things. Good way to assist your report when you're giving report to the hospital. Yeah, swelling, like we talked about with most ligament injuries, eventually probably bruising, but in our context of being the first people on scene for this, probably not bruising by the time that we get there. Knee dislocations. Dislocations of the kneecap itself, we've talked about before in class. That's not really what we're talking about here. And we're talking about here is dislocations of the tibia. And that's sort of a dislocation of the knee joint itself and not just the patella. Posterior dislocations are our most common dislocations. Medial dislocations occur very mechanism-based. So when we get a medial dislocation of the patella, it's because we had some kind of force that came in from the lateral side and pushed it medial. We splint these like we splint any other knee injury, probably with a long splint that goes fully down the leg, and then maybe we secure one leg to the other, or we secure it directly to the stretcher somehow so that we can limit that hip mobility. Distal femur fractures or proximal tibial fractures, or fractures of the patella themselves. If it doesn't look too bad, we splint the limb and keep the knee straight. In our case, that's what we're going to do no matter what, unless we have those absent pulses. And then we might apply traction to see if we can line something up. And if that works, then it does. And if it doesn't, then we'll just splint it and move on. Never use a traction splint on these. We use traction splints only for our mid-shaft femur fractures. Patella dislocations normally happen in the context of some kind of athletic activity. I told you guys earlier that the first one that I ever went to, the athletic activity, was trying to climb into her bed that was lofted 6 feet in the air, but to a degree, that's an athletic activity, trying to climb up that high. Usually these displace laterally. Once you see it the first time, it's super obvious. It looks like your kneecap is shifted off to the right. Here it says splint the knee in the position that you find it. Here in New York, we are allowed to reduce these when they occur laterally. Often, we're going to get real creative here. Often, these patients will present with their, all right, point this down at all. Often these patients will present with their knee bent like this, and in this case, if it's lateral, that means it'll be over to this side, so my kneecap is over here. What I have done for every one of these reductions that I've ever done is I stand right here, and I have preferably another EMT or medical, someone who knows generally what's going on here, stand at the foot, and I put my hands like this on the lateral patella, or the patella that's been dislocated laterally. And I said, okay, we're gonna count down from three. When we count down from three, whoever's at the foot is gonna slowly apply some traction to start to straighten out the leg. And as they do that, I'm going to apply force to the lateral patella. And then when I apply force to the lateral side of the patella, usually pretty quickly it just pops back into place. It can take a good push. There's nothing wrong with giving it a good push to get back into place. You're trying to overcome basically the tight point as it pushes itself over the lateral part of the femur joint, or the lateral part of the femur where it intersects with the knee joint. And then pops back into place, and usually they have a very immediate reduction in pain, and we try and get them to go to the hospital because it's what's best for them. Injuries of the lower leg, we get a fracture, we splint it, we go to the hospital. Ankle injuries. Probably the most common ankle injury that we have is an ankle sprain, and those usually come from either ankle eversion or ankle inversion. For some of these most commonly sprained joints, it can be helpful to, hop on Google, and over time you'll start to pick them up if you look it up every time that you go to one of these calls. And you can usually find a nice picture like this. Drag this over. Oh, wow, that's really small. All right, well, this is pretty low resolution, but you can usually find a nice picture like this, and that helps you learn the different movements of the ankle. And then when you give your report, you can give a nice, accurate report. So eversion is this rotation outward, inversion is that rotation inward. Dorsiflexion and plantar flexion, we point our toe up, we point our toe down. Those ones are usually pretty easy to remember because when we talk about the sides of the foot, we have our dorsal and our plantar side of the foot. So dorsiflexion and plantar flexion. And then abduction or adduction, we know those because those are just standard terms for movements towards or away from the midline of the body. Knowing those words can make us seem very competent when we go to give report on something like this. We splint these the way that we normally would for an ankle. We're going to immobilize at least up to the knee. It's kind of hard to immobilize one joint below the ankle because we're talking about, the joints of our phalanges of the foot when we're talking about that point. So really, we want to stabilize the entire foot and at least up to the knee. We can do that with a SAM splint or one of our commercial splints, anything like that. These also can often be splinted really well if you have good bulky pillows by taking a pillow, putting the foot on top of it, and then wrapping the pillow up over the top of the foot, wrapping that up in some Coban or some triangle bandage. And then that pillow just provides a nice, big, soft stabilizer around the entire ankle. Foot injuries, whole different range that we get here because we include in that the heel of the foot all the way down the carpals or the tarsals and the metatarsals and into the phalanges. We splint all of these pretty much the same way in that we just stabilize the entire splint or the entire foot. We leave the toes exposed. That can allow us to continue to do serial assessments of our CMS because we can, at the very least, pinch a toe, check that capillary refill. If that capillary refill is staying below 2 seconds, then we know that our circulation at least is in a good state, and we can do our motor and sensory with the exposed toes as well. I think that is, about it for what I had to say about those specific injuries. Stop my share really quickly and just go back to the Zoom call. I'm not sure exactly how long this video ended up being. I won't know until I end the meeting and see how long the recording is, but I'll get this one up right away and put it on the YouTube channel and then also on the course page. And I have my tablet in my car so that I can do a recording for the exam so that I can still write like I would in our normal review sessions. Just won't be on my Blackboard. It'll be on a tablet. So look forward to seeing you all then. Your exam is on Monday. Be here at 6 p.m. We are going to be on the downtown campus, even though we're not going to be doing any skills, just keeps it easier. We've been on the downtown campus for a week now, and we're going to be on the downtown campus for every class after this one. So we're just going to stay on the downtown campus for Monday.